Well, hello. This is the second recording that I'm doing here back to back with the with the previous one. So, if you address the CVA one first, you'll see that there's a cross reference here. So some of the slides will overlap as we would expect them to. So TBI is traumatic brain injury. It is exactly that. It is traumatic in nature, and as we've talked about, one of the types of brain injury. So we'll head into the content here. You'll see it looks different, but I've highlighted, I was saying, but it looks different in the fact that I highlighted a little bit. We're going to now understand the presentation of traumatic brain injury, etiology, signs, symptoms, so on and so forth. Again, talk about some performance skills and differences in presentations and such. This will look somewhat similar, but also have some unique differences as well from our previous discussion. Again, these are linked to accreditation objectives that we have to teach and as part of the content for the curriculum. So this should look familiar. And this is the similarities and differences. And when it looks, I edited it and I looked and it looks like I highlighted both in red, TBI and stroke. Actually left it as CVA and stuff. Anyway, you know me, I have these little boo-boos here and there, and that's okay. But if we look at the difference for etiology and origin of injury, whereas CVA can be ischemic or hemorrhagic, the TBI can be diffuse or specific. We talked about this in neuro. It can be very diffuse in nature, just like a hemorrhagic stroke could be for CVA. Or it could be a very specific focal type of injury, right? Like a coup contra coup injury that we talked about. But difference here is it could be external to the injury, like if you're being assaulted or you hit your head against something. That actually causes part of the problem. In fact, what ends up happening is, imagine watching this type of the embedded video here, but even if not, you have one hand open and in the fist, you put the open hand over the fist. The fist is your brain, the hand is the skull, and if you have the brain moving back and forth from the skull, it could abrase up against the skull, and that can cause trauma. So you can have primary and secondary traumas, just like you can from stroke. And as a result of that, have additional injuries that are either focal or diffuse or some combination thereof. So talk about it, and it depends. Brain injury can look very, very, very unique in a lot of different ways. But yeah, what we do and how the hemispheres and the short-term client needs are going to look relatively similar. Won't be exactly the same, but look very similar. And again, this idea of economics, socioeconomic status, age, risk factors, severity of injury mechanism, all that remains the same, right? It's the same for both these conditions. The difference here is that the type of brain injury is a traumatic one versus non-traumatic. So you're kind of following down that category here, right? We talked about stroke in the previous lecture. This is that slide, nothing new, so I'm not going to drag this out again, is that talk about inconsistencies with understanding definitions. I refer to some of my work that I've done, and my doctoral work had to do with education of brain injury and stroke survivors, and education and access to resources for this community entry, re-entry, integration, reintegration. That was one of the hardest pieces, getting us all on the same page. And that was the late part of the previous decade, right? So it's been a while, and we still are just making baby steps towards it. So that's likely going to continue, and it's just a matter of you being aware of it. Again, like I said previously, just where you're at is defining it, and how it's measuring it, and that could be one way to at least get more consistency, even though the evidence says that there's not a lot of consistency. So let's look at this here. Incidence and prevalence across the board here. 5 million people live with a disability due to traumatic brain injury. So numbers look different than stroke. About 1.4 million will acquire or sustain a traumatic brain injury, and you have upwards of 80, 90,000 newly disabled persons annually. Children are 0 to 4 are the highest category of injury. When I used to do this lecture live, I would say, why do you think this is? Unfortunately, it's because of things such as some type of child abuse, shaken baby syndrome, different things like that that cause that type of injury. The second highest category is young adults. For some of the things we talked about in neuro in particular, where you've got the axonal pruning, synaptic pruning, and that could be part of those reasons there. And then older adults greater than 75 years old are the third highest category. So key areas of categories. Males 1.5 times more likely than females to acquire traumatic brain injury. And most causes in general across the board are from falls, usually with the elderly, but not always, motor vehicle accidents across the board, but with those young adults in particular, and interpersonal violence across the lifespan for different reasons. Now, history of a traumatic brain injury is important here. Not so much talking about concussions here, or concussion syndrome, or multiple concussions, except that's evidence that's starting to tease itself out. But when we talk about traumatic brain injury here, if you've had a brain injury, the risk of having a second one is the evidence is showing you're about 3 times more likely to get one, and a third TBI 8 times normal. So this exponentially increases. Not entirely understood, but part of it could be part of the undiagnosed or unmeasured or ununderstood measures that are impacted or affected by this that could have something to do with that. So missed things were stuff that just doesn't ever recover. So that's that. So we have some categorization here. In this presentation, we're not going to talk about some of these things. This is in your readings, and this is part of the stuff you're going to get otherwise. But we have 3 categories. This is medical categorization: mild, moderate, and severe traumatic brain injury. Of course, mild is never mild, right? Just like with stroke, and it should be moderate TBI. Apologies for that. This is the categorization of it, right? So mild TBI described as at least one of the following, LOC is loss of consciousness, any loss of consciousness. Memory loss, including any anterior or retrograde amnesia, either or, doesn't have to be both. So what happened before or what happened after immediately the injury. Some kind of focal type of neurological deficit, and a Glasgow Coma scale of 13 to 15. And again, you could get that from your Glasgow Coma scale references. LOC is loss of consciousness. That's going to be lost less than 30 minutes, and then amnesia is less than 1 day across the board. Moderate TBI is a Glasgow Coma scale of 9 to 12. Loss of consciousness between 30 minutes to 24 hours. Huge category, right? But yet that's what the evidence shows. And amnesia, same thing, between 1 to 7 days. So another huge category. And then your severe TBI is defined by a Glasgow Coma scale of 3 to 8. Loss of consciousness is greater than 24 hours. Amnesia is greater than 7 days, so greater than a week. So that's your categorization. You're going to see a chart. You're going to see somebody that says they've got a moderate TBI. This is what you're going to expect. What that doesn't tell you is the lasting impacts, right? How does that affect occupational performance and cognition and all the systems and motor performance and everything that we've talked about? That's where your upcoming courses after this are going to start to play themselves out, where you're going to learn how to do process and practice evaluation and intervention type of ways to address this moving forward. Different definitions are important here. We talk about definitions being inconsistent. A little bit of consistency is kind of important here, just so we have this commonality. We did this with our neuro. Of course, we think being able to do this is kind of important because it helps us to understand context moving forward. So traumatic brain injury is an insult or injury to the brain other than something you're born with, congenital, degenerative, or acquire this way. That's a whole degenerative condition, is another category. That's caused by an external force with some kind of resultant diminished abilities. This may impact occupational performance. Closed head injury, acronym CHI, is any type of brain injury that does not penetrate the skull. Could be a concussion or some kind of concussion syndrome, right? So it's closed head injury. Penetrating head injury is when the dura mater is damaged, and then there's resultant penetration of the skull by an object. So you have some type of resultant force, and that impacts things there. Subdural hematoma, SDH, is when blood collects within the dura mater, leading to increased intracranial pressure. And then what ends up happening is you have the skull, the dura, pressure that pushes the brain further in, and that secondary damage is what actually will do more damage with the subdural hematoma, and probably more diffuse in nature. We talked about this a bit in neuro. That's why the asterisks are there. Diffuse axonal injuries, when there's axonal damage with acceleration, deceleration of the brain against the skull. So it could be, I try to show the hemispheres side by side, if they're shaken back and forth. So during an assault or some kind of somebody being shaken, that could just cause micro traumas that may not show up, or if they do, you're not going to know really how they impact occupational performance to actually see it. Again, beyond the context of this discussion. The coup contra coup injuries, when the head strikes a stationary object with focal injuries. So I've talked about car accidents or motorcycle accidents or different things like that. The car accident could actually be where you have the skull and the brain traveling, and then you come to a stop, and then the brain crashes into the skull, again causing primary and then secondary damage. Coup contra coup, the point of contact, and then the secondary point of contact. So it could be frontal lobe and occipital lobe, like we talked about in our neuro class. Couple other things here as well too. Intracranial pressure is ICP. This is the overall pressure exerted on the brain and skull from the brain tissue and cerebral spinal fluid. That's what it's called. When this increase is due to some kind of trauma, like traumatic brain injury, the results may lead to brain damaging, including brain herniations, where the brain herniates more inferior, or shifts of tissue from where they normally would be, and that ends up causing part of your trauma and damage that leads to injury. In these instances, the skull may be at least partially resected to relieve the pressure. So that in order to do that, you might see shunts that are placed in so that swelling can drain. Often those skull pieces are put in the abdomen until they're ready to be put back. Then that person has some kind of maybe put back, maybe a metal plate or something over once everything's recovered. And then there's a whole nother category, which we're not talking about here, is the coma and states of cognitive functioning. This is decreased states of consciousness, cognition, primarily due to an acquired brain injury, or if for survival, there's a medically induced coma, which then lets the body to recover in these more impacted states. It could be measured by the Glasgow Coma Scale and the Rancho Los Amigos level of cognitive functioning. And so the levels of cognitive functioning, the Rancho Los Amigos levels, are the ones that allow us to understand those levels of recovery, and that you tend to recover to a certain degree all the way up to normal with those Rancho Los Amigos levels, but that you never go back unless you get a new injury, but you may not go all the way back to quote unquote normal or the highest level of functioning with those Rancho Los Amigos levels. So I went ahead, like I said, I put this up, the left and right hemispheres, because this remains the same, right? Same we talked about neuro, same I mentioned in the CVA lecture, same it remains here. This is exactly the same. So I want to go ahead and just point that out to you. So possible impacts of traumatic brain injury. This is one of those challenging kind of things, because the reality of it is that I'm giving you an exhaustive list here. And when I give you this exhaustive list, I think one of the important things to think about is that how these present can be in any combination. So if you kind of think about this, what makes brain injury kind of complicated, right? And this is a reflective question: what are the implications and how can you propose to address this? If you take each one of these and kind of categorize them as mild, moderate, or severe, and then combine them in any combination. So somebody might have 1, 2, 3, 4, 5, 6, up to whatever, 20 of these. There's so many different ways that these can interact with each other. There's no one assessment, and there's not going to be, that's going to help us to identify one of these things over another, or if one's worse than another. You could have, look at the first couple, you could have mild headaches, but moderate seizures, but severe confusion. Not necessarily, but something like that, right? And how do you address that? So what you're learning about is how to take the, it depends of how these possible impacts can kind of happen, and then use them to be able to make the decision to address what we have to address in occupational therapy, as well as to prioritize what the impact is upon the performance skills of the client factors, or anything else moving forward. But in addition to that, you have secondary effects of traumatic brain injury. Due to the complications from injury, or the traumatic brain injury as a result of intracranial pressure or the edema, um, this could be a big, this could be any, there could be any number of things that happens with it. So these secondary effects could be any fractures, right? So you can have, so it could be a skull fracture. You could actually say your motorcycle accident comes to mind. Say you've then fall off the bike as a result of this, and in doing so break a leg or break an arm or a clavicle or something, or a rib. That then could be a secondary effect of that and affect your recovery. You can have cranial nerve damage. You can have abnormal autonomic nervous system responses, respiratory responses, the intracranial hemorrhage, the ischemic damage, and also infections because of the TBI, because foreign tissue and matter have gotten in there into the brain matter and such moving forward. So in that regard, any combinations of these could actually impact how things are and kind of affect your any kind of your results moving forward. So when we look about TBI effects of the lifespan, we have the same type of idea, and this is where you have the idea, IDEA. It's the same type of situation that you would have, especially in regards to that we were talking about with stroke, where you can have the same type of things happen. The etiology and the outcomes could look different because we're categorizing, understanding them different. But how we address it and the resources available to it could easily be exactly the same here. So we talked about this in stroke. I'm not going to repeat this on this particular slide here. A couple things that I want to talk about, though, related to brain injury in regards to this particular content. And that is related to our roles and responsibilities. So just to explain these, one's serial casting, one's heterotropic ossification. These are unique to brain injury, not just, but they kind of tend to be more so than, say, stroke. So serial casting could be utilized to manage severe spasticity. Remember, this will not fix the spasticity, my friends. It will not change it. It addresses the secondary orthopedic issues related to that or hemiparesis, hemiplegia, and that orthopedic secondary kind of tightness. It could include dropout casts, bivalving. And so what happens is that if you've got a limb that's on a certain loss of range and it's stuck there, you can create a cast. That cast then is bivalved, it's cut on either side. And then what ends up happening is then you could then place the arm in there, and what you do is you create new casts that increase that range over time. Keep in mind that without the casting, it's probably going to go back. So people can't wear casts all the time, but without them, it may get worse or stay the same or impact things. So you have to kind of gauge that. Consider cognitive level. You want somebody to be agitated to have that. Probably contraindicated with acute inflammation for obvious reasons, open wounds, unhealed fractures, or hypertension. And heterotropic ossification is HOs, bone growth outside the normal bone growth areas. Exact cause is unknown. Don't know why it happens. Yet the thought is that the current main thought is that it could be connected to this idea of miscommunications after neurological injuries. May be confirmed with an X-ray, so your medical team helps figure this out. And in the acute stage, it becomes highly vascularized, and usually in the elbow and in the knee. And so what ends up happening, you can't do anything about it in the immediate time frame. Once it ossifies, once it becomes bone, then it can be cut out. This is just one of the secondary effects of brain injury. So what does OT's role look like? Well, similar but different here. I'm just addressing a couple other kind of things here too. We of course address independence. It looks like I spelled caution wrong. So what these few errors I make here and there. Use caution with the idea of plateauing. I talked about plateauing in that chapter in the Pedretti textbook. That was a reference in neuro. Could always make reference again for you if need be. Um, but we didn't really talk about it. It was one of those things that I said, just hold as a resource. We just, in this version of our class, we didn't do it, which is fine. The idea of plateauing is this, is that um, when you decide what somebody needs for OT and how they accomplish it and what their goals are, is going to be related to how insurance reimburses what they're doing and what they can reimburse for. That external guide, that external constraint can end up being an impact upon what you do. And so they might benefit from more services, but they have plateaued. That's really, the chapter explains it better. You read the chapter, it can kind of help. Let me know if you want access to that again. But what it ends up doing, and that chapter talks about stroke, but the idea is the same for brain injury, is that you have to be cautious as to when you set up, they can't benefit from any more skilled services at this time. So just interesting side discussion. Assistive technology, augmentative communication, this keyboard, switches, different ways to communicate when there's aphasia or praxia or decreased cognitive states in particular. Basic activities of daily living, this idea of the functional independence measure and its misalignment of sorts with OT. We'll leave that discussion for another class as well too. Instrumental activities of daily living, all this, of course, we know this. And functional ability, it is something that OT can and should do. How you define that, how you address it, definitely is it. If all you're doing is walking, that's PT, right? But when you engage in some kind of mobility, even if it's from a wheelchair, from a seated position, you're going from one place to another. That's where it becomes functional. Just it's a version of how I talked about with communication, like with our speech language pathology colleagues. So some of these terms here, it could be with any of this, right? Ankle foot orthoses. These are hinged or not hinged, that kind of bend or don't bend, or they're stiff, and they keep foot drop that sometimes happens as a way to keep it from affecting when the step phase of gait is occurring. KAFOs is knee, ankle, foot orthoses. These are bigger, larger ones. They kind of provide a bit more support. And different ambulatory devices, straight cane, regular single cane, small base quad cane, little quad pieces, small base quad cane, large base quad cane, a standard walker, rolling walker, hemi walker, which has an arm support for the hemiplegic side, or different types of wheelchairs. A lot of different things too that are kind of linked to that or engaged in what OT might do. We could potentially be connected to them as well. Through the community, through mobility and accessibility, of this idea of topographical orientation that we talked about a little bit in neuro. How to get around, how do you get around? Do you know how to get around, especially with cognitive and even motoric deficits as well too. The idea of work. So this is where a neuropsych assessment that I talked about for the stroke discussion could come in. It's often required for return to work, but it doesn't always reflect ability and performance. You as the occupational therapist will be the best one to do it. Contextual, real life engagement in the activity is probably going to be the best way to do it. Doesn't change, right? It's just what we learned about last quarter in neuro. It's exactly the same. And we need to know about job requirements and performance, what's expected and required. Driving, what are the laws and testing, and we have to watch out for seizures. In the state of Illinois, you have to be seizure free for, I think, double check this, but I think it's been at least 6 months. You do not, you should, it's a gray area. You should have an exam to clear yourself to return back to driving, but you could go back possibly. And that's one of those kind of variables right there. At least that's how it has been. So I often would tell patients, clients, family members is that to protect yourself, not let alone just other people, you should do that so that you get cleared. And that usually is not an issue. Support's huge. It's not really just about that deficit. It can't be, it shouldn't be, and it isn't. It's about education. We talked about this starting last quarter, right? Not just in the neuro, but in other courses. The family, asterisk, whoever that person is, it's going to be that education in red and all bold is very important. Educate, 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 because the time that they're going to be living with this condition within a day is within a week, within a month, within a year, within their life is way more than you're ever going to spend with them. So you need to educate them so that they can maximize that. There could be support groups. There's the clubhouse model, which is traditionally um, one that allows for it was for different needs in the community, more mental health type needs, and it's expanded to brain injury and now stroke. Um, and I just point out I've been on the board and for one of the two in the area, and co-founded the second. Um, and so these are really good resources. So one in particular I highly recommend is the Midwest Brain Injury Clubhouse as a resource for those who may need it. And you can Google them and find out what they do. It's really, really, really creative. And of course, institutionalization. So going to a nursing home possibly as a last resort. And even then, trying to gauge if that's something you're going to do or not. Across the board, you have a couple different things and I mentioned about this as well too, um, in, uh, in, in talking about stroke, but also talking about brain injury here is just kind of pulling this over to here. OT's role is that the level of care really is based upon where you're going to be. If it's acute, inpatient, subacute, day rehab, outpatient, long-term, all of these things. Acute is more managing medical complexity. Inpatient, you start to address strategies and behaviors, right? So what are strategies? Can they be internalized, like we talked about with cognition and neuro? Or are they not internalizable type of thing? Then we get to subacute, where you work more on stabilization. And then day rehab, living in the community, extended time of skilled services, long-term care to do, or should we be doing long-term care facility like a nursing home? As I pointed out before, different items for you to consider. I'm not going to go over this here because the same rules apply, including, even though it's the stroke guidelines here, I did include them here. It is not stroke, I realize that, but I went ahead and left it in here because the cognition piece is important, and that return back to work and driving, even though the conditions differ, remains important, especially with some of those cognitive changes that you're likely going to see in brain injury versus stroke. But again, it could vary. That's a bit different than it depends. But yeah, so there you go. So a couple other organizations. This slide's a little bit different here. The Brain Injury Association of America is a good resource and reference, not just for you, but for your families. This is the clubhouse, Midwest Brain Injury Clubhouse that I talked about. Again, it's a crossover. This is organizations, so crossover conditions. Stroke survivors empowering each other is a good reference resource. And a couple centers for independent living, Access Living and Progress Center. You'll be learning more about these moving forward. The idea of independent living is that nothing about me without me. Don't try to tell me how to live my life. I can live in the community. It's how the community's set up that impacts my disability versus living there otherwise. And so these are all good resources for you. Your embedded case, the person's name is different here, but the same ideas go. I've just pulled those questions out here for you to look at. I'm not going to go over those details of that particular case, but just to kind of to show you that that is here. We want to keep in mind those same kind of questions that we did for stroke. Very parallel, very consistent here, very transparent. So make sure you take the time to do that and reflect upon that in your course. Again, I leave you with your references and resources. And again, just like with stroke, there are many, 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 many more than we have here, but these are good ones to kind of have access to and moving forward. All righty. Thank you.